right, so we'll give it a couple minutes for people to join, and then we can begin.
Are you waiting for, oh, okay.
Yeah, so people are actually joining through the YouTube live, so we won't see them over here, but they'll be able to see what you're presenting. So yeah, we're just gonna give it like a couple more minutes to have a couple more people join, and then I'll introduce you, and then you can begin.
Okay, yeah, I was like,
All right, so we can go ahead and begin. So hello, everyone. Welcome to our shadowing session today. Today we have Dr. Jaclyn Tomsic, who is an oral maxillofacial surgeon. So welcome.
thank you. It's great to be here. Thanks for having me. So you want me to just get started?
Yep, you can go ahead and get started.
Okay, so good evening again, everybody. Thanks for having me on my medical message. So again, my name is Jaclyn Tomsic, and I am a board certified oral and maxillofacial surgeon. I practice in Cleveland, Ohio, which is actually my hometown. I practice in a dual practice. I'm in private practice, as well as I am a part-time academic faculty with the oral maxillofacial surgery residency program at Case Western Reserve University. as well as University Hospital's a level 1 trauma center here in Cleveland. Like I said, I'm board certified. I obtained my board certification in 2015. And then I was inducted as a fellow into the American College of Surgeons in 2017. So I thought I'd start out a little bit by just talking about what oral and maxillofacial surgery is. So as defined by AMIS, which is the American Association of Oral and Maxillofacial Surgeons, which is our governing body, oral and maxillofacial surgery, or surgeons, are considered the experts in the face, mouth, and jaw surgery. We perform surgery in all areas of the cranial maxillofacial skeleton, both the hard and the soft tissues. So we treat disease, injuries, and defects in the head, neck, face, as well as the oral and maxillofacial regions, both externally on the face and skin, as well as internally in the oral cavity, which is where the name of our specialty is derived. Obviously, oral referring to mouth, and maxillofacial is the jaw, refers to the jaws and face. Oral maxillofacial surgery is an internationally recognized specialty. It is recognized in over 80 countries worldwide. So other names that you may hear about, or common names. So our full name is Oral and Maxillofacial Surgeons, or OMFS. People also refer to us as OMF surgeons, or simply oral surgeons, or maxillofacial surgeons. So any of those names are synonymous with OMFS. And just a little bit about my training as well. So we go obviously high school, and then we most typically go to a college or undergraduate, 4-year undergraduate university to obtain a bachelor's degree. I went to a small university called John Carroll University in Cleveland, my hometown. I obtained a bachelor's of science, major in chemistry, minor in biology. Then directly out of undergrad, I attended dental school for 4 years at Boston University. And then out of dental school is actually where I participated in the match program and matched into OMFS residency, which ironically today was actually our match day. So there's 4th-year dental students all across the country who found out what oral maxillofacial surgery program they're going to today, which is kind of exciting. But in any case, so then as part of my oral maxillofacial surgery program, it's a 6-year program, and incorporated into that is when I then go back to medical school. So from Boston University, I matched into Detroit Receiving Hospital, which was affiliated with Wayne State University School of Medicine. So for the next 6 years, I was completing my residency, as well as attending medical school and getting my medical degree. So I actually ended up graduating with the Wayne State School of Medicine class of 2010. And then I graduated from my oral maxillofacial surgery residency 2 years later in 2012. During that time, I did a 1-year general surgery internship. So that is just like any regular medical student. That's directly your intern year is your first year out of medical school. So when I graduated in 2010, I did from 2010 to 2011 my general surgery internship before completing my final year of residency. And then so I graduated OMFS in 2012. And then I chose to complete a fellowship. Fellowships are optional. For most medical specialties, fellowships are optional. So oral maxillofacial surgery is similar. So I did choose to complete a 1-year orthognathic surgery fellowship at Georgetown University in Washington, D.C. So that's in a nutshell what my training looked like. So my day-to-day, so I started out, I said I practice both in private practice and in an academic setting. So I do at this time practice 5 days a week. I practice in my private practice on average 3 to 4 days, depending on my schedule, my OR schedule. While I'm in the private practice on a daily basis, I see a variety of consultations, postoperative appointments, as well as scheduled procedure appointments. The other day, it's a day and a half that I'm not in my private practice. I am working with the residents, either staffing the resident clinic or working with them in the operating room, doing operating room cases. I do also take trauma call at, like I said, a level 1 trauma center. So that is also with the residents. I share it with 2 other surgeons in the community. So on average, I take about 2 weeks of call for every 6-week period. So again, actually, this week I happen to be on call. So sometimes the weeks that I am on call, often I have to go in after hours to do add-on trauma cases or add-on emergency cases. So sometimes then I could work a little bit later days. But for the most part, I do stick to a pretty regular 5-day schedule or 5-day-a-week schedule, and have a lot of time have weekends off. So it's not too bad. So with that was just a very, very, very brief, obviously, overview of my background and my training. So now I'll get into, I have, I think, 2 case studies for you to present. So the first one is a 22-year-old Caucasian male with no significant past medical history, who presented with a 2-day history of facial pain and swelling, decreased oral intake, limited oral opening. The patient reports intermittent oral, jaw, and tooth pain for several years, but developed severe 10 out of 10 pain about 1 week ago that did not subside. Following the pain, he then developed swelling 3 days prior to presentation under his chin and jaw, which then progressively has increased in size, and which is why he then decided to present to the emergency room. He endorsed odynophagia, which is pain upon swallowing. However, he denied dysphagia, which is the inability to swallow. So those are very commonly confused terms. A lot of times they're used synonymously, but it is very important to know the difference. So he was able to swallow, it was just painful to do so. And something that we use a lot when we're describing these types of patients is he is handling his secretions. Someone who has a significant facial swelling may have difficulty handling certain secretions, and that is an indication that this is very, very serious. So in this patient, he did have a significant facial swelling, but he was able to handle his secretions. He had no respiratory distress. He did not have any difficulty breathing. He was able to communicate with us his symptoms, and he happened to be afebrile at 10 presentation. So when we're taking a history, we always, or when we're seeing a patient doing our intake, we always take our histories. So his past medical history was non-contributory. He denied any past surgical history. He denied taking any medications, home medications. He had no known drug allergies, did report food allergies to tomatoes and shrimp. He smokes a pack a day, drinks alcohol socially on the weekends, and reported also social marijuana use. He denied any other illicit drug use, and he denied any significant family history. So the review of systems, our review of systems is a term that we use in medicine. It's part of our history and physical. It's where we go through kind of all the symptoms all the different body systems and just check for any additional positives. So we're looking for positives or pertinent negatives. So mainly for him, most of his review of systems were negative, minus the ENMT, which is ear, nose, mouth, and throat, or head and neck area. So constitutional symptoms just means kind of like overall description. So they were negative for any fever, chills, anorexia, weight loss. Malaise is kind of just like an overall feeling, just kind of like not good. It's kind of like a blanket term, like for someone who just feels like blah, honestly. Eyes negative. He had no vision changes or blurry vision. Again, his ear, nose, mouth, and throat, which is pertinent to our patient. He did obviously have some mouth pain and throat pain, and he also reported that it did radiate to his ear as well, which is not unusual. He denied any nasal symptoms. Again, respiratory, which would also, so this is what I said, a pertinent negative. So respiratory for us is actually an important pertinent negative. So for somebody with a very significant facial issue or facial swelling, it could potentially cause shortness of breath. So in our patient, he did not have shortness of breath. He did not have difficulty breathing, wheezing, or coughing. So those were positive signs for him. Cardiovascular, he was stable. He was not having any chest pain or tightness. GI or gastrointestinal. So the GI tract does start in the mouth. So his slight painful ability to swallow does actually go under GI as well. But his other GI symptoms were negative for nausea, vomiting, diarrhea, or constipation. Musculoskeletal is kind of muscle and joint symptoms, which were all negative. Again, neurologic, were all negative. He did not have any syncope or fainting spells, altered mental status, headaches, or dizziness, and his psychiatric was negative as well. So that's a typical review of systems. Next, obviously, anybody that you see in an emergency room or in your office, you're going to take vital signs. So these are his vital signs. So I guess to make it a little bit interactive, is there anybody, are these vital signs normal? Does anybody see anything abnormal in these vital signs? I guess with YouTube, are they able to answer?
Yeah, actually, just give it like a minute because there's a short lag for YouTube. So, but if people do answer, I will read them out for you. Yeah, I guess you can go ahead. I don't think anyone had an answer for that.
Okay, that's fine. So in general, these vital signs are normal, 36.6. So in medicine, a lot of times we use the Celsius actually. So 38 is considered febrile or a fever. So his temperature is normal. Pulse 94. Again, anything under 160 to 100 is normal pulse. So this is normal. Respirations anywhere between 12 and 20 is normal. So again, he has normal respirations. His blood pressure is slightly elevated. His systolic, 120 over 80 is normal. So his systolic blood pressure, 143, is slightly elevated, could be due to the pain, but nothing too significant. And then his oxygen saturation, he is setting 100% on room air. So again, that's a good stable. So these would be considered stable vital signs. These are his lab values. I think it's easier for me just to go through it. So looking at these lab values, this is a white blood cell count or a CBC or a complete blood cell count, as well as a chemistry. So the top portion, the top four are the main CBC values. The white blood cell count measures infection. The hemoglobin and hematocrit is a sign of red blood cells and anemia, or the presence of it, and then your platelet count. So looking at these values, the white blood cell count, especially in this presentation, is the most important. He has a significantly elevated white blood cell count. A normal white blood cell count is anywhere between 4 and 10. So his is elevated 22.8, so that's very significant. The hemoglobin and hematocrit are normal values, and the platelet count anywhere between 150 and 450 is a normal platelet count, so that's also normal. These are his chemistries. Again, this measures electrolytes and different glucose and different measurements. Again, these are all, I'll just tell you, I mean, I don't expect you to know this. These are normal values. Glucose is slightly elevated, above 100 is elevated. So his glucose is slightly elevated, but not out of control. A normal sodium is 135 to 145, so that is normal. A normal potassium is 3.5 to 5, so that's normal. Bicarb 23 to 28 is normal. And the BUN creatinine, which measures kidney function, both of these are normal values as well. So again, the white blood cell count is his main abnormal value, very elevated. So the PE is the physical exam. So this is a well-developed male, awake, alert, and oriented ×3. He's in no acute distress, so he's talking to me, able to communicate with me, and is cooperative. Again, his eye exam is normal. His pupils are equal, round, and reactive to light and accommodation. His extraocular muscle movement is intact. His ear, nose, mouth, and throat exam. So MIO is a maximum incisal opening, or basically how wide you could open your mouth. So a normal oral opening is anything 35 millimeters or above. So this is a significant clinical finding. He has a limited mouth opening, only at 15 millimeters, and he has pain with opening, which is consistent with his spatial swelling. The floor of his mouth, FOM is floor of mouth, is slightly firm and also mildly elevated and painful, with increased pain on the right side of the mouth, the floor of the mouth. The tongue is slightly elevated, but is not protruding out of the mouth, which again, when you have severe swelling, it tends to protrude out of the mouth. The uvula, which is the little soft tissue structure at the back of the throat, is midline. Teeth 30 and 31, which are 2 molars on the bottom right of the jaw, are painful and very broken down. When you look in the mouth, he has noted poor oral hygiene with generalized gingival inflammation. So the head and neck, the rest of the head and neck exam, normocephalic, atraumatic. That's just a medical way that we describe the head, meaning that it's a normal shape and size. The neck is tender to palpation, anterior and lateral. Okay, the anterior and lateral neck. And then the submental area is this area here, right underneath the chin. And the submandibular areas are on the lateral side underneath the chin. He does have submental and submandibular edema or swelling and tenderness on the right side, which is where his swelling is. He also is noted to have tender and swollen lymph nodes on the right side of his neck associated with the swelling. His trachea is midline, which again is a good indication that he's not having any airway issues. Again, respiratory is breathing comfortably on room air. His cardiovascular is, he's hemodynamically stable. His extremities are warm and well perfused. Neurologically, he's intact. He has no altered mental status, and his appropriate mood and behavior is appropriate. So, going back, so at this point, this is kind of like your decision-making tree. So at this point, you've seen the patient, you've talked to the patient, you have reviewed lab values, and you've done a clinical exam. So now you need imaging. Most of the time when you're consulted as a consultant, which we are a consultant service, these the images have most likely already been done. So the image that you would get in this instance would be a CAT scan or a CT of the soft tissues. So we have a patient with facial swelling. So we need to find out where this swelling is located, where it's coming from. So the appropriate imaging for this situation is a CT. So the emergency room went ahead and got us a CT of the head and neck. So this is, CT comes in 3 views, coronal view, an axial view, and a sagittal view. And it's just the way that the CT is cut. So this is actually a coronal view. So if you can see this is, if your face is cut into multiple slices up and down like this way. So you're looking straight at the patient's face. As you can see, you can kind of see the eye sockets up here. This is the sinus. So in this, we know that this area here, especially on the right side, that is where our patient's swelling is. So if we're looking at the CT, you can see this, what we call a rim enhancing lesion right here on the right side of his face and neck. So this is his mandible, which is cut. This is, kind of halfway through the face. So you see each side. So this is very consistent with where his swelling is. He has a rim enhancing lesion or collection. We call it a fluid. And this is consistent with an abscess. And these, the left side and the right side are just 2 separate cuts on different areas of the CT that show where this abscess is located and where it's extending from front to back. So this is a coronal cut. This is another cut of the CT. It's called the axial cut. So this is if you're cutting your head from front to back this way. Okay. So the front part or the top part of the screen, the white kind of U-shaped upside down U here, that is the front of the jaw here. Okay. And you can see behind it, directly behind it, again, is this lucent, darker collection. And again, it's what we call rim enhancing, and it's well-defined, meaning that there are distinct borders, collection of fluid. Okay. And again, these are at different, the left side and the right side are at different levels. So you can see that this extends not only from front to back, which we saw in this previous CT. These are different levels from front to back. And then when we're looking at this cut, which is up and down, the collection extends at different levels up and down. So we know that this is a 3-dimensional collection. And finally, this is what we call a sagittal cut of the CT. So this is if you cut your head this way, okay? And the slices are going kind of like this across your head. So again, if you look on the left side, the front, you can appreciate the jaws, and you can appreciate the teeth coming out of the jaws. And then directly behind the lower jaw, you can again appreciate this rim enhancing fluid collection. So this fluid collection, this rim enhancing, this darker lucent area on the CT, that is a clinical abscess. So a collection of purulence or pus or exudate, all of those would mean the same thing. It is a large abscess that has collected and developed within the soft tissue structures within the head and the mouth, which has caused external swelling. and that is why his symptoms have progressed. So at this point, after seeing the CT, you make a clinical decision. For us as OMF surgeons, the clinical decision is obvious. This is a large abscess that needs to be drained. This is not something that is going to just go away on its own without any surgical intervention. So with this patient, you know, he was explained that he has developed a large abscess that needs to be surgically drained. We went from there. This is an Panorex X-ray. You can see the arrow there is pointing to the bad tooth, actually. So if you look at this tooth on the right side of the X-ray, you can also see where there is a lucency between the roots of the teeth. This is an abscess that originated from this tooth. It was left, it got out of control, and that's when abscesses, you know, grow within the bone. Then they get big and they erode away the bone, and then they go to the closest structure, which is your soft tissues, which is how he developed the abscess and the swelling, the facial swelling. So I kind of already went through this. So now what, you know, you have to diagnose it and then make a plan. So I'm sure you guys can already guess. So his diagnosis is a 22-year-old with significant facial cellulitis, which is essentially inflammation of your tissues that can happen any tissue on the body, with associated submandibular, like I described, is underneath your mandible on each side, and then submental is underneath your chin. So he had abscesses. That's where the fluid collection was. It's of odontogenic origin, meaning that it's from a tooth, an abscessed tooth, the molar tooth. He does meet mild SIRS criteria. SIRS is systemic inflammatory response. It's a criteria that we use for assessing patients and their risk of developing sepsis. So he did meet 2 of the 4 criteria. He had a pulse that was greater than 90. He had a 94 heart rate. And then, like I said, the big kind of red light in his exam was the white blood cell count. So it was above 12. It was significantly above 12. So it was 22.8. So obviously this is someone, he is currently stable, but we don't want him to go downhill. So the plan, he needs to be admitted to the hospital because this is not something that can be treated as an outpatient anymore. So we admit him for IV antibiotics because, again, oral antibiotics are not going to be strong enough to treat this type of infection. We make him MPO, which means he can't eat or drink. He has to prepare for surgery. And we take him to the operating room for incision and drainage of the abscess and removal of the teeth. So that is essentially, you know, what we did. A patient typically stays in the hospital for 2 to 3 days after the surgery to receive IV antibiotics, receive pain medications, and then make sure that he is progressing appropriately. So this is a pretty common case that we as oral surgeons see on a regular basis because unfortunately there's a lot of people in the community that just fail to take care of their teeth, and they develop the most common cause of a significant facial infection is a bad tooth. There are other causes such as an infected sweat gland or an infected hair follicle. Those can also lead to pretty significant swellings that need to be drained in the same way. But for us, this is something that we see a lot. So I believe that is the end of the first case. So I think I have one more case if we want to go to that, or if we want to do questions. I know I see there are a lot of questions coming in, so I'm not really sure. I want to be respectful of everybody's time too. So whatever you think.
I think we can move on to the next case and then take questions at the end.
Okay, I think the next case is a little bit quicker, so I'll kind of move past it pretty quickly so we have time for questions. So So case number 2 is a 27-year-old male. He presented to the emergency department via EMS after a self-inflicted gunshot wound to the face. So this was unfortunately an attempted suicide, which we do see from time to time. When he presented, he did not have any loss of consciousness. He was actually communicative, awake and alert. However, he had, because of his injury, he had significant facial and oral bleeding. So the patient was actually intubated, or a tube was placed down his throat in the emergency department, which is done often for airway protection. So he wouldn't. So that happened, and then we were consulted because of his significant, obviously he shot, gunshot wound to the face. So he's got significant facial injuries. Again, his histories you take every time you see a new patient. He had a history of depression and anxiety. He was supposed to be on medications. He wasn't compliant with them, which is unfortunately very common with patients and with psychiatric diagnoses. He's never had surgery before. He denied any surgical, past surgical history, allergy to aspirin, was a social drinker, non-smoker, denied using any other illicit substances, and denied any significant family history. So in this case, in the first case, I went through a pretty detailed review of systems. Well, review of systems is something that you're asking the patient, you just you'll go through, you'll just kind of make your own little review that you go through with all of your patients, and you ask them and they answer. So in this case, this patient, like I said, was intubated, meaning that he has a tube down his throat. So when you're intubated and you have a tube down your throat, you're sedated, because if you weren't, then you would not be able to tolerate the tube. So in these cases, which for a lot of our trauma patients, we see these situations a lot, we're unable to do a review of systems. So his review of systems is essentially he's sedated and intubated, so we really can't do anything. So going on to his vitals, again, so his vital signs, his temperature 36.2, that is a normal temperature, pulse 61, again, that is a normal pulse rate. So his respiration, so like I said, he's intubated. So when you're intubated, you are connected to the ventilator is breathing for you. So in this patient's case, the ventilator was breathing for him at approximately 14 breaths per minute, which is normal, which was set, which is a normal setting. His blood pressure is pretty normal. That's a normal good blood pressure. And again, his oxygen level was 97% on the vent. And I'm not really going to get into this. I mean, that's for medical school and beyond. These are just vent settings. Basically, the settings that are placed on the vent to breathe for the patient. So again, lab values, looking at these lab values, again, I won't go through all of them one by one, but they're pretty much normal. The only kind of abnormal thing he's got slightly elevated white blood cell count, nothing serious. That's very common with trauma patients. The only other difference, his hemoglobin and hematocrit are slightly decreased, which also is consistent with the fact that he's a trauma patient and he came in with significant facial bleeding. So he lost some blood from the trauma. So it's very common for these patients to have a decreased blood level when we take the labs. The rest of his labs, his chemistries were pretty much normal. His physical exam, so again, he was well developed, he's sedated and intubated. He had his eyes were clear. Because he's sedated, we can't do all of the exam tests, so we're unable to evaluate his extraocular muscle movements, ear, nose, and throat. So the OETT is oral endotracheal tube, so he's got a tube in his mouth. He had dried blood in his nose. He has malocclusion, meaning that he can't, his bite is off, his teeth are all crooked and not coming together properly. And both his mandible, his lower jaw, and his maxilla were grossly mobile to touch. So these are indications consistent with his injury. Scalp and forehead abrasions, again, consistent with his injury. The rest of his exam was pretty much normal for being sedated. He was, you know, breathing comfortably on the vent. His cardiovascular status, he was, you know, hemodynamically stable, and neurologically obviously sedated. So imaging, again, for a trauma patient, we also get a CT. We get a slightly different CT. This is for trauma. So we're looking at the bony structures. So this information is gained from the same type of CT that we presented before. This is obviously his facial skeleton. And you can kind of obviously see we have a lot of fractures here, concentrated on the left side of his face, but the right side of this image. So he's got a fracture through his orbit, the top of his orbit, the top all around the side, the inferior orbital rim. This is his midface through his maxilla. Obviously, you can see a midline mandible fracture. So he's got fractures in his upper face, his midface, and his lower face. Fractures of all the facial bones. So this is what in OMF surgery we call a panfacial fracture. And obviously, this needs to be repaired. So, assessment, 27-year-old male with panfacial fracture, secondary to a gunshot wound. Like the previous slide showed, he had a mandible fracture of his lower jaw, maxilla fracture of his upper jaw, and fracture of his orbit too. In these cases, these patients are already admitted. Usually they're admitted to the trauma team. We also place them on IV antibiotics because this is an open wound, can easily get infected. And we plan to take him to the operating room to fix everything. And obviously for this type of patient, a psych evaluation is recommended and required. So I think the final slide, the next slide, I forgot I had these. So these are actually, this is this patient, and these are intraoral, obviously, pictures in the operating room. So on the left side, so to do this type of surgery, to get to the orbit, we do what is called a coronal incision. So we make an incision behind the hairline and kind of peel the scalp back, which is essentially what you see on the left side. In the left side of picture, the right side is just another photo of the different flaps that we make during the surgery. So that is the top of his skull. This is a picture on the left side. It's hard to tell. Obviously, I know what it looks like, but so the left side is the plating of that orbital fracture that you saw. That was above his eye. So the retractor, again, is retracting back his scalp. This is if you were standing at the head of the patient, behind the patient, looking down on him. This would be, the plates are his superior orbital rim. So right underneath the plates, essentially, are his eye socket. The picture on the right shows the plated maxilla, which is the upper jaw. So you can, appreciate that the plates cross the fracture sites and reapproximate that. And then the next, this is the mandible. Okay, the picture on the left is someone whose jaws are wired shut. So we had to wire his jaws shut. That's a form of maintaining stability for him. And then the picture on the right is the fixated mandible. If you remember from the initial CT, he had a fracture right through the middle of his jaw. So you can see that this is now well approximated and reduced back into place. And I believe the last picture is the final product. So this is the scan. After it's all fixed, you can see the plates across everything. And like we love to say in OMF and facial trauma, we put Humpty Dumpty back together. So I think that was the end of the case. Sorry. So I think just to wrap up, I was talking just about my medical school experience. So again, like I said, I went to Wayne State University, which is in Detroit. I personally really enjoyed my med school experience at Wayne State. Kind of a fun fact, Wayne State is actually is the largest single campus medical school in the country, meaning that we have every year we have 300 students plus in our graduating class. So, and we only have one campus. We don't have any satellite campuses. So because of that, you know, I had a very diverse training, very diverse patient population, getting to train in Detroit. I really was very spoiled. It's just really a lot of good pathology and very good training. I train at there's multiple tertiary care centers, which are big universities that basically everybody sends their patients to these centers because they have every specialty available. And because we had Detroit is such a large medical city, really got to do a lot of hands-on training as medical students. So again, I really enjoyed my experience at Wayne State, and just some take-home tips on medical school or dental school or any kind of professional healthcare graduate school. You know, really you have to establish a study method and a schedule early on. Everybody learns in different ways. And you have to figure out, you know, once you get to this level, you know, it's very steep learning curve. And you really have to find a way that works for you and stick to that schedule, and you know, go from there. Seek out mentors who you can bounce ideas off of. Obviously, training centers like this have tons of great mentors. I had tons of people that I you know, really respected and learned well from. So take advantage of those people when you find them. And then of course, remember that self-care is very important as well. So obviously medical school and residency training is very intense, but you do have to remember to take time for yourself. You know, take care of yourself, get enough sleep, eat well, sleep well, because that's very important, not only for your own well-being, but for the well-being of your patients. So I think, yes, that is it. So I guess we'll move on to questions from here. So I guess, do you want me to just go through these? I do see some in the chat box.
Yep. Yeah, you can go ahead and do those ones.
Okay, so I'm just kind of going to start from the top. It says, someone asked me, is there any surgical method with zero recurrence rate? You know, that's an interesting question. I don't think I've ever been asked that question. So there are a lot of surgeries that we do that are curative. So it's not really a method. It just depends on what the surgery is for. So for instance, you know, the trauma case that I presented, as long as the patient doesn't get re-injured, then that, I mean, yes, there's a very low risk of recurrence. So yeah, there's many surgeries with zero recurrence rate. Just kind of depends. That's a case-by-case question. What made you decide to become an oral surgeon? Are there any hardships you face now that could have been prevented during your residency or learning experience? So I became an oral surgeon because I really, throughout dental school, I realized that, you know, dentistry really I didn't really have a passion for dentistry. I really had a passion more for medicine and surgery. So instead of, I did consider just going to medical school. And then I was encouraged and introduced to oral maxillofacial surgery, which allowed me to do both. So that's really why I became an oral surgeon, because it gave me the opportunity to not only become a surgeon, which is something that I really wanted to do, but also go to medical school, which is also something that I wanted to do. So for me, it was kind of like the best of both worlds. I'm not sure hardships now that could have prevented. I mean, honestly, everything that I told you in my tips is kind of things I learned through trial and error. I didn't sleep as much as I should have during residency, so that could have definitely improved my learning experience. But other than that, that's really all I have to say about that. Are there any myths regarding oral surgery you would like to debunk? It's actually a pretty good question. I guess the biggest myth that I like to debunk for oral surgery, for oral surgeons, is when you see an oral surgeon, they really are a physician and a surgeon. They are very little dentists, which we often get called. Yes, we go to dental school, but that's kind of required. But we really, once we get it past that and go into our oral surgery training, we really are more medical physicians and surgeons than we are dentists. So that would be the main thing that I would love to debunk about oral surgery. Were there any specialties you were considering before deciding on oral surgery? I think I went through, when I was in medical school, every rotation that I went through, I absolutely fell in love with, and I probably considered every single one of them because I just think I loved learning medicine. All the different fields are just so interesting to me. But I think if I had to do it over, I might consider anesthesia. I obviously, as a surgeon, I work a lot with anesthesiologists. Anesthesia is a very just fascinating field as well. So in my second life, maybe I'll be an anesthesiologist. Were you torn between a dentist and surgeon, moved to OMF? I can't kind of already answer that. I was not torn. I realized I didn't really like dentistry that much. So that's why I chose to become a surgeon and do oral maxillofacial surgery. What does your day-to-day schedule entail? I went through that in the presentation. What do you enjoy most about your profession? So many things, honestly. The fact that I do get to kind of incorporate all my backgrounds into one specialty is very unique. The dental education that I have, the medical education, and then the surgical education, I really do use it pretty much on a daily basis, which is, pretty cool. I also really enjoy just working with so many other professionals. I enjoy the hospital setting. I enjoy being in the OR. So I just enjoy just everything that I get to do, both in the office and in the operating room, and just the variety of things that I get to do on a daily basis. It's never the same thing every day. And that's what really, in my opinion, it makes our specialty very unique and enjoyable. Let's see. So someone asked about my typical day, which I think I covered in the presentation. Most interesting case, most interesting topics that you learned in training. Honestly, for me, the trauma cases, like what I presented, is probably one of our more, they're definitely, I presented a very complex case, a panfacial fracture. Those are some of the most fun and interesting cases, because obviously with trauma, no two cases are the same, no two injuries are the same. So you get to kind of, every trauma is a different puzzle that you get to put back together. So I really enjoy that. And throughout training in Detroit, which we saw a lot of trauma there, to now I'm in Cleveland, there's a lot of different trauma that goes on. So I really you learn every time you do trauma, from the first time you're a resident to now as an attending in private practice. Every time you do a case, you learn something new. So I would say that's really exciting. Work-life balance, burnout, that's always a question with anybody in medicine. I have a great work-life balance because I have partners. So I work in a group practice. I have 3 other partners. So because of that, it's easier to take time off and for family or for vacation or what have you. So that's one of the reasons that I decided to work in a group practice. because I do have that flexibility. So because of that, I really do feel like I'm able to have work-life balance. You know, I work 5 days a week. A lot of the times I have weekends off. The weekends that I'm on call are scheduled well in advance. So, you know, I'm on call, like I said, two out of every 6 weeks, roughly on average. So that's not really that bad for, you know, a surgeon. And because of that, because I'm able to kind of make that work-life balance and stick to it, at least in my experience, I have not experienced burnout. I think it, you know, that is very important when you get to be, you know, a doctor, physician, whatever kind of doctor you are, making your schedule so it's something that is doable and livable and enjoyable for you is important and will prevent you from experiencing burnout. So always, as with a lot of things, easier said than done. But it definitely is very achievable. This question, how did COVID affect your job? Did you work more hours? So, you know, with COVID, we were like anybody, like everybody from about 6 weeks, mid-March to about May, all elective surgeries were canceled. So we were only doing emergencies, but we were working. So obviously our workload decreased significantly, but we were pretty busy on a daily basis with emergencies and seeing patients. Still, again, the 2 cases that I presented here were cases that, you know, COVID or no COVID, those cases come up all the time. Trauma happens. So that's not something that we could have put off for COVID. Infections were another thing. So I worked. I was never off, and obviously I never worked from home. I didn't work more hours. I worked less hours because we were only doing emergency cases. But I did feel very, very lucky to be able to still work during the initial shutdown and still be able to help people because people still, you know, needed treatment. Do oral surgeons during pandemic? How do oral surgeons practice infection control? I mean, really, you know, we practice under sterile conditions on a daily basis. That's our standard. That's our protocol. So honestly, other than the increased PPE that everybody had, our infection control practices were already in place. So kind of really didn't affect us that much in that way, other than the additional, you know, PPE and N95s, face shields, that kind of stuff. What is the most difficult or interesting case you have ever had? I think I would go back to, again, the trauma cases are always difficult, interesting, and fun, all in the same breath. All right. Does your work involve collaboration with plastic surgeons? Yeah, it does. We collaborate with both plastic surgeons and ENT, or ear, nose, and throat surgeons, neurosurgeons as well. Really, we collaborate with a lot of different doctors across all specialties. You know, some of the collaborations we do with plastic surgeons, you know, we oftentimes rotate trauma call with them. So sometimes we collaborate them with trauma cases, and sometimes I don't personally do cancer surgery, but for those in my field that do cancer surgery, they collaborate often with both plastic surgeons and ENT surgeons to help with reconstruction of the face and mouth region when patients have oral head and neck cancers. What is my favorite procedure? So my favorite procedure I actually didn't present That is a procedure called orthognathic surgery, which is jaw repositioning surgery. That is actually what I did my fellowship on. So I did a whole year of this surgery. And that's for patients who are born with craniofacial deformities or discrepancies between their jaws. So we plan, and now we do it all virtually and virtual. It's called virtual surgical planning. We do everything through computer-based software to plan cutting their jaws, moving them and repositioning them into a new position, and then fixating them back to that new position. So that is, hands down my favorite procedure to do from start to finish, from the surgical side as well as the patient side, because these surgeries really are very life-changing for the patient. And it's just so exciting to see. Once a patient, it's also, it's a long process. Usually the surgery from start to finish takes anywhere between 1 and 2 years, because there's like preoperative work that needs to be done and then a healing period. So it's just so exciting to see the patient from the beginning, and then when they're finally done, and just to see their satisfaction and their excitement with the new result. So I get really excited about those surgeries. What motivated you to do this specialty, and what was a difficult factor for you when applying or when you got accepted to your school? So again, what motivated me was, the combination of surgery, medicine, and my dental background really provided me to incorporate everything. A difficult factor for applying is that it's very competitive. So I applied broadly. I wasn't sure I was going to get in. I was very lucky. I did match in my first go around. And so, again, like I said, today happens to be the match day for us. And there's a lot of happy people out there today, and there's probably some less so, but some disappointed people. But with anything, if it's something that you really want, if you don't get it the first time around, just stick to it and try again. If I hadn't matched my first time around, I would have tried again, did what I had to do to match the second time around. So, what was the most challenging moment in your training residency, and what motivated you to continue? The most challenging is just, you're really pushed hard. Surgery, it doesn't matter what surgical specialty, surgery is very, very difficult. It's very demanding. Even with restrictions now, you still work 100 hours a week during training. So it's demanding on a physical level, as well as a lot of, your educators, your teachers can be very demanding, a lot of different personalities. The most challenging for me was dealing with those different personalities, the people who really just wanted to, were just basically not nice to you on purpose. That was their way of teaching. And that was very difficult for me. Some people take it personally. Some people are, it's easier for them to get through it. Just have to realize that you're going to come into contact with a lot of different personalities with any type of surgical or medical training. And you just got to realize that you deal with these people for a very finite, period of time. You have to figure out how to deal with them until your training is over. So I was able, and believe me, some days were harder than others, but being able to, look at the light at the end of the tunnel, just keep your goal in mind. That's what motivated me, is that, at the end of the tunnel was my completion of residency and, the goal of becoming a surgeon. So I kept that in mind. And then before I knew it, residency was over. So it does go by quick in hindsight, of course. Let's see. What are some personality traits of some of the best people in the medical field? Just perseverance, determination, and just the desire to learn, because medicine, surgery is a lifelong learning process. So those are some of the best personality traits that I know, and the people that I admire, and traits that I try to live by as well. How come you decide to go to medical school after dental school? Well, that's just kind of the way it's done when you become an oral surgeon. And I think I touched on that earlier. You know, medical school was something that I determined that was important for me, and I really wanted to do that. So I feel very lucky and privileged that I was able to accomplish that goal. What are the bread and butter procedures you see as an oral surgeon? So some of the bread and butter cases are what I presented. Some of the bread and butter outpatient office procedures that we do would be wisdom teeth removal and placement of implants to replace missing teeth. Those are probably the two most common bread and butter procedures that we do. And what is something about OMF surgery that you believe more people should know and appreciate but do not? I guess kind of just, I want more people to know that we are well-rounded surgeons, physicians with a dental background, but we're much more than dentists. I think I went over that multiple times. That's the biggest thing that I would want people to understand, is that we really are very well trained to do what we do. We live in this area of the body. We probably know the facial anatomy as good as anybody. And we really are very dedicated, and we love what we do. And we take a lot of pride in what we do. So if you come to see any oral surgeon, you are, going to get someone who is very well trained, very well educated, and a very intelligent person. And I think that is the last question. So.
Yep. All right. Thank you so much, Dr. Jaclyn Tomsic. Your session was amazing. I definitely learned a lot from it, and I got a new perspective into oral maxillofacial surgery. So thank you so much. We really appreciate it. And for everyone else who is still watching, make sure to fill out the Google Forms to get your shadowing hour. It'll be due around 7:25 p.m. Eastern Standard Time. So make sure to get it in by then. But thank you so much.
Well, thank you, everyone. I hope you learned something from it, and good luck with